So with respect to malperfusion, we wanted to examine the outcome of patients presenting with acute DeBakey-1 dissections complicated by malperfusion who were treated with surgical repair and implantation of the AMDS. Patients between 18 and 80 years of age presenting within 14 days of an acute DeBakey-1 dissection were included. We excluded patients if they were an extremist, had known documented connective tissue disorders, or had aortic dimensions greater than 45 millimeters in the proximal descending thoracic aorta. CT scans were performed at 1, 3, 6, and 12 months postoperatively. The primary endpoint was the status of malperfusion after AMDS implantation, and we defined malperfusion as the loss of blood supply to a vital organ caused by branch arterial obstruction secondary either to the dissection. And this was assessed clinically and radiographically on the initial CT scan and on the immediate postoperative CT scan. Supraortic vessel malperfusion was defined as a high-grade stenosis greater than 75% or occlusion of the vessel due to compression by the non-perfused false lumen, leading to vascular leading to interruption of the flow within the affected vessels. This definition of supraortic vascular malperfusion excludes those patients whom had a dissection involving the supraortic vessel, but no compromise of blood flow. From March 2017 to January 2019, a total of 47 patients underwent emergent repair of an acute DeBakey-1 aortic dissection with AMDS implantation. We identified radiographic malperfusion pre-operatively in 26 of these 47 patients, or 55%. Herein, we examined this cohort of 26 patients. Their demographics are as follows. The average age was 63, 2/3 were male. In all of these cases, the AMDS was successfully deployed. Axillary arterial cannulation was used in 92% of these patients. The median deep hypothermic circulatory arrest time was 34 minutes, and the mean antegrade cerebral perfusion time was 32 minutes. The time to implant the AMDS was 3 minutes. 30-day mortality was 7.7%. The development of a new neurologic injury was 2 of 26 patients, or 7.7%. There were no cases of device-related aortic injury or branch vessel compromise. 5 patients required dialysis in the postoperative period. There were 24 patients included in the analysis of efficacy, for a total of 66 vessels with malperfusion being identified. 2 patients were excluded due to the lack of a postoperative CT due to early death. The first patient presented with preoperative bilateral common carotid artery occlusion and postoperatively was noted to have hypoxic encephalopathy. The second patient expired secondary to multisystem organ failure. So with 26 of 47 patients having radiographic malperfusion, 2 being excluded, this table highlights the vessels involved in malperfusion in the remaining 24 patients. The y-axis across the top identifies the arteries involved, starting with the coronaries, progressing through the aortic arch, down through the abdomen. The x-axis represents the 24 patients. The majority of patients you'll see had 2 to 3 vessels involved. 1/3 had cerebral malperfusion, 1/4 had visceral malperfusion, and 1/4 had radiographic evidence of renal malperfusion. Post-operative, or the first initial CT demonstrated that 96% of vessel malperfusions resolved after AMDS implantation without a secondary intervention. The supraortic vessels, 21 of 22 malperfusions resolved, 13 of 14 visceral malperfusions resolved, and 15 of 16 renal malperfusions resolved. The very last point, 3 patients presented with pre-operative spinal cord injury manifest with lower body paralysis. And surprisingly, all 3 of these patients recovered their lower body function and had no evidence of spinal cord injury at the time of discharge. Of the 66 vessel malperfusions, 1/3 involved the supraaortic vessels. As noted, there were 4 patients who had pre-operative clinical evidence of cerebral malperfusion in the emergency department. Only 2 patients had a new neurologic deficit identified post-operatively. All patients that were identified as having a neurologic deficit, these occurred in patients with either dissection or malperfusion of a cerebral vessel. No neurologic injury or deficit was identified in patients with anatomically normal cerebral vessels. So these are some, we have three slides or 3 patients demonstrating what we have seen. On the left-hand panel, this is a patient with a DeBakey-1 dissection. On the right panels, we see the post-operative CT demonstrating complete re-expansion of the true lumen within the aortic arch, and at the level approaching the distal descending thoracic aorta, complete re-expansion of the true lumen. Courtesy of my colleagues in Montreal, the panels on the left demonstrate a preoperative patient CT with virtually occluded bilateral common carotid arteries, and the panel here demonstrating occluded SMA with no perfusion of the renal arteries bilaterally. Post-operatively, we can see that both of the common carotid arteries are now perfused, and in the right lower panel, we can see that the SMA is now perfused along with both renal arteries. Again, preoperative images, type A aortic dissection involving the arch, not uncommonly seen. The left common carotid artery is malperfused, and similarly the left common femoral artery. Post-operatively, the left common carotid artery is now perfused, as is the femoral artery, and on the left panel we can see the aortic arch and the descending thoracic aorta true lumen re-expanded. Secondary procedures were required in 3 patients for disease-related interventions. 1 patient had left renal artery stenting for static malperfusion. There was 1 patient that required superior mesenteric artery stenting, again for static malperfusion, and a patient that had delayed presentation required fasciotomy of left lower extremity. Key points. Aggressive aortic arch replacement for patients with dissection of aortic arch branches resulting in cerebral malperfusion has been advocated, and in the hands of expert aortic surgeons in carefully selected patients, this may be safe. However, the AMDS is a safe and reproducible adjunct to the current standard hemiarch repair in patients with acute type A aortic dissection, without adding any significant time or complexity to the procedure. When faced with malperfusion, the AMDS is capable of effectively treating malperfusion in over 95% of cases. Static malperfusion can be addressed effectively after life-saving surgery. A unique characteristic in this cohort was the healing of malperfusion involving cerebral vessels and the reversal of dissection-induced paralysis in 3 patients. Based on the data presented, we advocate for a single-stage management of malperfusion during the index operation without delaying life-saving surgery.